Afternoon, everybody. Welcome to the fourth webinar of the joint action on addressing chronic diseases and healthy aging across the life cycle. Today, we will discuss the prevention and care of diabetes. Diabetes was chosen as a case study by the joint action CHRODIS to answer the question on how to strengthen healthcare for people with chronic diseases. I'm going to present ourselves. We are the moderators. We are Anna Galinat and Pearson from EuroHealthNet. And we will first give you a few instructions on how the webinar will be run. So today we have two speakers which will present later on. We will have a presentation of approximately 30 minutes. And then we will have some time for questions and answers. To make the webinar as smooth as possible, we will first mute all the participants so we don't hear any unnecessary noises. But we really would like to to welcome you. We want this to be an interactive webinar. So please, when you have questions, use the chat on the right-hand side of the GoToMeeting and put your questions or share your comments or share any ideas and challenges with us. And then we will address the questions after the presentation in the question and answer. You can also keep the questions for yourself until the end, and then we will unmute all participants after the presentations, and then you can put your questions at that point. I also need to inform you that this webinar is recorded. So if you don't want to be recorded, you just stay muted all the time. And the webinar will be presented on the website of the Joint Action, and also on YouTube when it's going to be edited. And then finally, we will also send a questionnaire with a short evaluation, and we would be very happy if you could fill in that questionnaire. Oh yeah, good. So also for your information, you can follow and go to Twitter with the hashtag chronic diseases and using @EU_CHRODIS. And now I think we have spoken enough. So I will introduce our two speakers for today. Dr. Marina Maggini is a senior epidemiologist at the National Center of Epidemiology of the National Institute of Health in Rome, in Italy. And she leads this work package on diabetes. She leads it together with Dr. Jelka Zaletel, who is senior expert in diabetes at the National Institute of Health in Slovenia. For those who did not attend the first webinars, just kind of very short reminders. We had webinars on the three main topics of the joint action, which were health promotion and disease prevention, on the management of patients who have more than one chronic diseases. That was last week's presentation, and then this week on diabetes, as I mentioned. So Marina, I think you are starting, so this is now over to you.
Welcome. Welcome to all the participants. I'm sorry for these problems with the audio of my computer. As you can see now the presentation.
Yes.
Okay, perfect. As it was already said, this work package was about diabetes that in the frame of CHRODIS was used as a case study on strengthening healthcare for people with chronic diseases. Diabetes is often considered a case study as an example for chronic diseases because it's a disease common and serious, but it can be prevented using the knowledge that we already have. And moreover, people with diabetes is at an increased risk of other diseases as cardiovascular diseases, eye problems, food complications, and so on. Diabetes, at least in part, and complications with diabetes can be prevented with correct treatment and also with recommended lifestyle changes. Though then it is often used, people with diabetes is often used as example of people with chronic diseases. The objective of our work package was to improve prevention and care of diabetes through the improvement and coordination of the action of member states on diabetes, including the exchange of good practices. Another objective was to analyze the national diabetes plan in Europe and to identify enablers and barriers to the development, implementation and sustainability of national diabetes plan. The work package, our work, was organized in 5 tasks, each of one dealing with a particular topic related to diabetes, and the 5 tasks were led by some colleagues from all over Europe. The plan and the method that we used to reach the goal of our work package was based on knowledge and expertise sharing to generate our other new knowledge. And so the activities goes through identification of existing strategies, identification and analysis of existing strategies and programs, plans, then the analysis and comparisons among these strategies and plans, and through all this process we formulated recommendations and guides. This is a list of some of the most important activities that we have conducted. Most of these activities and the results of these activities have been presented through documents, reports that are available on CHRODIS website. So if you are interested, you can read the full documents on CHRODIS website. Some of these documents are not yet public, but they will be public in the next months. The first activity that we conducted was an overview about practices on diabetes prevention and care, a qualitative overview through a questionnaire. I will present some results after these first slides. Then we conducted a qualitative overview by country, conducting a SWOT analysis on the policies and programs, including also successful strategies. Through these activities we collected also a number of good practices, because one of the objectives was the sharing of good practices among European countries. And then to reach the objective of the definition of recommendations, we put in place a process, a very long and complex process that goes from the definition of a preliminary list of quality criteria, then through the definition of diabetes, and then the definition of recommendations. Another set of activities was related to the National Diabetes Plan. Also in this case, we mapped National Diabetes Plan across Europe. The various plans were analyzed. The analysis was then the basis for the definition of a policy brief on National Diabetes Plan, and also for the definition of a guide for National Diabetes Plan. Also these documents, together with the report on National Diabetes Plans by country, are or will be available in the CHRODIS website. So all the documents, the publications are available all of you. This is a very brief picture of the results of the overview on practices on diabetes prevention and care. This is just to show you some results. The imaging that we can, and the key message that we can give through this analysis is that policies on prevention, disease management, education, training of professionals exist throughout Europe, but they are not always well implemented or are not implemented at the national level, and often they are not evaluated. In fact, often, in particular, long-term outcome indicators are not used. The SWOT analysis was conducted, so the overview of policies and programs on prevention and management of diabetes was conducted to give an insight on what makes policies, programs applicable, sustainable, effective from the stakeholders' perspective. This is a representation of the content and the structure of the SWOT analysis that implies the analysis of internal and external conditions. So strengths and weaknesses are internal conditions that fall within the scope and control of the program, whether external conditions, threats and opportunities are those that are outside the direct control of the program. As an example, the economic crisis is an external condition that can be considered threats or also an opportunities. Some of our partners consider the economic crisis as an opportunity because it has it was sometimes the background and the stimulus for a revision of the model of care. These are a map of the countries that participated to the SWOT analysis. Almost 60 stakeholders were involved. And this is a mind map of the successful strategies. So these are the representation of the approaches, features, the capacity building, the characteristics that were considered the most important, according to the respondents, of course, the most important characteristics for a successful strategy. And according to the respondents, to be a success, a policy programs need to be dynamic, bottom-up, flexible, equity-oriented, and then we need to have a clear definition of care pathways, a strong leadership, the strategies has to be carefully planned and funded. And also the capacity building is intended as the development and strengthening of human resources, focusing on people with diabetes and professionals. This is a picture, a representation of some of the characteristics, the challenges and potentials that were identified by the partners, going from the growing prevalence of non-communicable diseases, which was considered one of the most important challenges, through the exchange of good practices at European level that was considered a strong motivator for action, and this was considered as a potential. So, as an example, to increase awareness among the growing prevalence of non-communicable diseases and exchange good practices may be actions that can allow the European countries to act in a more effective way on chronic diseases. The results of this analysis may be applied to any context across Europe because it derives from very different contexts, from countries that varies in organization of healthcare and political situation. And the results may be used by decision makers, managers, professionals, other stakeholders, by the patient, of course, to focus on key issues and to help in recognizing the areas for attention and areas that need to be faced. The recommendations were the definition of recommendations to improve detection and preventive intervention for diabetes, and overall to improve the quality of care for people with diabetes was the main objective of this work package. And this goal was accomplished through the definition of quality criteria before the definition of recommendations. So the process goes through the definition of a core set of quality criteria. I will show first this slide, and then I will come back to the previous one. The process goes from literature reviews to identify quality criteria and indicators, and these reviews were published. Then we identify and define a first list of quality criteria. This first list was reviewed by all the partners, and then a group of experts were defined, and through the procedure of Delphi procedure, these experts have defined a set of criteria weighted. I want to show you an example. This is the first criteria, the criteria that was charged as the most important criteria to improve the quality of care for people with diabetes. The criteria is practice design, and the practice design has 7 categories. And also these categories have a weight. So these categories may be considered indicators, and this is the criteria, the general criteria, quality criteria to improve the quality of care for people with diabetes. From these criteria and the categories of the criteria, we have formulated the recommendations. This is the first recommendation, which is related to the practice, the designing of the practice. So the first recommendation is design the practice, and the practice should specify aims, objectives, methods, and rely upon relevant data, theory, context, evidence, and so on. I don't want to read all the recommendations. Overall, the recommendations were 9. And the first one is the designing of the practice, and then the promotion of the empowerment of the target population, the definition of an evaluation monitoring plan, the comprehensiveness of the practice, the education and training that must be included in a good practice to improve quality of care. The practice must consider ethics and vulnerable groups. We need an approach for the governance of the practice. The practice has to have regular interaction with relevant system, and another characteristics that was considered important is the sustainability and scalability of the practice, even if it was not considered as the most important, but it is also one of the quality criteria that was defined. These quality criteria and these recommendations may constitute a tool for decision makers, healthcare providers, patients of course, and healthcare personnel to implement, improve, monitor, and evaluate good practices. They may be applied to various domains, prevention, care and promotion, education and training, and are also general enough to be applied in countries with different political, administrative, social, healthcare organization, and could be also used in other chronic diseases. And in fact, as I said at the beginning, diabetes was used as a case study. So the objective was to define recommendations that can be used also for other chronic diseases. All the activities on National Diabetes Plan was conducted in particular by the co-leader Yael Kazal, that now can present the following slides.
Okay, I'll make Jelka the presenter. Jelka,
hello.
Yeah, we hear you.
Okay, I will also give you the slides. Okay.
We see you as well.
Perfect. So with relation to National Diabetes Plan, the general logic,
Jelka, just one question. Yeah. We can't see your screen yet. Have you clicked on shared your screen? Yes, perfect.
Perfect, okay. So the task related to National Diabetes Plans was conducted by the same methodology and approach that Marina already described. And for the purpose of this joint action, we did define National Diabetes Plans according to IDF criteria. I'm just going to move to the next slide. Obviously, it's still Marina's screen, so I will ask Marina to put on the slide, please.
Okay, this is the next one.
Yes, please.
Can you see my screen?
No, we can't. It does. It's not.
Yes,
now
yes,
yes.
Yeah.
Okay.
It's okay.
Okay, perfect. So, yeah, perfect. Thank you. So the National Diabetes Plan is defined as any formal strategy to improve diabetes policies, services that encompasses structured and integrated activities that are planned and coordinated. Or the other definition was that it should be systematic and coordinated approach to improve organization and delivery of prevention and care of diabetes. This guide was also used to design the first questionnaire with which data was collected across 22 member states and the 2 states outside European Union. And this was the baseline data with which we wanted to give an answer about what national diabetes plans can make. So if they really have the ability to change the delivery or the experience of the patient with diabetes, or change the overall perspective of the country towards prevention and early detection of this disease. So to have a national diabetes plan is like a hammer. With a hammer you can of course nail a nail if you use it in a correct way, but if you use it in a not very usual way, you can also do more harm. Why we set this in the first case? Because we did have some impressions that, okay, it's nice, we have national diabetes plans, but they don't change anything. So to further go dig deeply into our data, we aimed to define the factors that facilitate the development, implementation, and sustainability of national diabetes plans. This work is presented in policy brief that is published on our CHRODIS website. So what are the major key messages from this policy brief? So the first one relates to the field of leadership. So the leadership, of course, has to be national or regional. If you have the regional organization of healthcare or federal organization, it is really important that multiple stakeholders are involved in leadership of this national diabetes plan to really have this broad perspective encompassed in its planning and implementation. And there has to be a really well-managed balance between what is centrally defined and what are actually the regional differences, and also to leave at least a bit of these regional activities to their own autonomy. And of course, adequate resources and capacities for implementation of the national plan, but also for monitoring and evaluation have to be in place. The second very, very important point is national diabetes plan to be well implemented and sustainable needs strong advocacy. From the work that we performed, it has been shown that it is best done by patient representation. It was very clearly stated that the representation of the patient should be already in the development phase, and on the other hand, during the implementation itself, the patient's representation is assuring that the implementation is really going into the right direction. The third field is flexibility. So the first flexibility is that national diabetes plans that are able to learn from its own experience really have strong implementation and sustainability. So if you write a national diabetes plan and nothing changes, and then you say, well, it doesn't really help us, it is not the end of the national diabetes plan. The next question should be then the monitoring. So what is really going on in a wrong way so that we cannot achieve changes, and to evaluate all possible steps that may lead to the next step. And of course, learning from others is a really important point also at this policy activity. In policy making, learning from others is usually very important and strong, and collaborating of member states in this joint action was a really good opportunity to learn from one another. As we saw, let's say in Lithuania already, national diabetes plan development was influenced strongly by the outputs and results of joint action CHRODIS. So this is probably how the working group or the steering group of the national diabetes plan should look like, not like a formal highly institutionalized format of a working group, but more like family, sharing food together with really a lot of trust. And then during the work in this joint action, our work package was asked several times. We know already what has to be done, but we don't know yet how to do that. So how you make this family type of steering group of national diabetes plan. That's why we went and dig into the field of leadership more deeply. Just for this presentation, I will use the description of leadership by Marshall Gans. So leadership is to accept the responsibility for what is the final result, to create conditions, but not for yourself. So to create conditions that enable others to achieve a shared purpose in the face of uncertainty. So the only certain things in leadership is that there will be unexpected events, and uncertainty is a very nice word to describe this situation. The guide for national diabetes plans is developed really to support this view to development of national diabetes plans. It is a companion to other products, so there are recommendations, there are set of criteria, there are two complementary methods, well-defined approaches to get to a sustainable and efficiently implemented policies. And this guide has got a very short description of topics that have to be represented in the National Diabetes Plan. They have there are the descriptions of the processes that the National Diabetes Plan has to support. There is a description of the organization of national diabetes plans that seems to work, and they are so generic that they can really be used to guide the development of national plans for any chronic disease, with the focus on a sufficient, efficient implementation. In this presentation, I would just like to focus on leadership again. So first of all, the top-down leadership is something that is really familiar to us, and we all know that it can be highly efficient in some cases because it really creates clear focus. It can create consistent and ongoing initiatives. It can set the priorities, it can bring energy to the project, and it can signal the commitment to change in the system. The top-down leadership is efficient if it translates the broad objectives into specific focus goals. It can have the full overview of the activities, therefore assess their complementarity, help them to integrate, and takes care of the balance among the activities. So the leaders who really work in efficient top-down leadership have to have the abilities to engage people and do this in a continuous way. But this alone cannot achieve the effective leadership for a successful implementation of the policies. What we do need is also a bottom-up leadership. The most important from these circles is probably the green one, knowing is not enough. Just to know something will not change the way how you act. And people adopt new behaviors by experiencing them, especially because we talk, of course, of adult people. The bottom-up leadership has to have certain specificities. Let's say that this leadership has to be aware of the change readiness of large number of people. It has to focus and has to help show the preconditions for the change in these people. It has to have the ability to see the goals of those people, the gaps between the real situation and the aimed situation, and what are the root causes for these gaps. This leadership should then support brainstorming of the ideas, trying out, monitoring, and adjusting. And as the last very important topic for this bottom-up leadership is that initially inertia for sure will exist. So having bottom-up as well as top-down leadership will really help these initiatives, plans, strategies to cover both important directions. But what we experience also in our healthcare is that there are many silos that do not communicate among each other. So leadership for linkage is the leadership that will bring to breakthrough changes. Top-down and bottom-up leadership still work inside existing boundaries, but the leadership for linkage helps that people, institutions, activities are linked in new ways and therefore create communication and linkage across the existing silos. These are the associated and collaborating partners of our work package. We are really thankful to them for all the work that has been done in these past 2.5 years. We have had more than 200 experts from all over Europe included in our work, and of course this couldn't be managed without many other CHRODIS partners that supported this activity. Thank you very much.
Thank you very much, both Marina and Jelka, for this really great overview of your work package. We haven't seen any questions in the chat panel, but let me ask now. We will unmute all and let me ask if people have questions.
And it is Sylvia.
Yes, Sylvia. Hello.
Can you hear me?
Yes, we can hear you.
I have one question. I saw that you were including all the successes so far with national plans, as some countries have some. What have you done with the failure? Because often we learn more from failures than from successes. Have people shared as well their failure?
Yeah, thank you for this comment. Actually, the focus of all joint action was to identify best practices. So we had to have a really struggle to come also to the failures. But since we approached every country or every responder by individualized questionnaire with additionally having a interview with the respondent, and since we got also the SWOT analysis when we can really tell about positives and negatives at the same time, that's why we came out with such strong messages about how the policies have to be developed to really be implemented and sustainable. So what we learned from failures is that if you think that just by having to have a national diabetes plan writing will be a magic button for your country, well, that's not true. So this is probably the most frequent myth of national plans, that having a plan will by itself change something. And what was also nice, or not very nice, but interesting to find that although every country claims that patient representation is assured in national diabetes plan development and implementation, only half of the countries have patient representation at the steering group. So there is still room for improvement.
Thank you.
And from this, if I can add something, from the SWOT analysis, we get some suggestion about the weaknesses on the programs for diabetes prevention and care. And the participants identified some of the most important challenges. As an example, the complex administrative rules on management procedures, or the poor coordination between local, regional and central authorities, or the personal changes that can affect the partner's contribution, the fragmentation of the existing diabetes prevention and care, and there are a long list of these characteristics that are not failure, but the characteristics that may cause the failure of a program of a strategy.
Thank you.
Thank you.
Are there more questions? Well, I guess in that case, we'll come to the end of the webinar then. As Marina and Jelka mentioned before, if you have questions still after this webinar, just please send them to us and we'll forward them. And yes, if I can just remind you about the evaluation questionnaire that we will send you later today, that would be great. And then this was in fact the last webinar of a series of webinars that was presenting the joint action. But we will also have 2 more webinars that are more related on patients and on healthcare professionals. And these will take place in December, on the 6th and on the 13th of December. So if you are interested, you will also soon receive the link to register to those webinars. So on behalf of the Joint Action CHRODIS and on behalf of all the people here present, I would like to thank you very much for attending this session, and I wish you a great rest of the day. Bye bye.
Bye bye.
Thank you.
Thank you. Bye. Bye. Bye.
Yes.